Welcome to the Physician Associate Podcast.
Hello and welcome to this episode of the Physician Associate Podcast. My name is James and today I'm delighted to be joined by three guests from Northern Ireland.
I'm Dan Meehan. I'm a Physician Associate. I work in emergency medicine and I'm also the course director of the Physician Associate program here at Ulster University.
I'm Gareth, Louise. I am a consultant in acute medicine and nephrology in Antrim Area Hospital, and I'm our trust lead for the Physician Associate programme.
My name's Louise Dubras, and I am the Dean of the new medical school here at Ulster University. I'm also a GP. And just to give that little bit of context, the School of Medicine started training doctors, medical students, but we've very recently welcomed the Physician Associate programme into the school.
Perfect. Thank you, guys. I really appreciate you all coming together to make this episode. I thought it'd be really important to make some episodes that focus on physician associates in different parts of the UK, in the devolved nations, just to see how things might differ for the profession. I am guilty of being an English-based PA and only really thinking about the NHS in England, and I thought it'd be interesting to see how that might vary across the UK. Who wants to start by I guess my first question is explaining the history of the profession of PAs in Northern Ireland?
Well, my first introduction to the PA concept was in September 2017. I had just been appointed a consultant the month before, and I was asked to chair a Royal College of Physicians update day in Belfast, and one of the previous FPA presidents was talking about the PA concept, and I was intrigued. But I thought, hey, I'm going to advocate for these guys because the concept seemed quite sound. They'd been tested in England and certainly America, and it was another piece of the puzzle to our workforce issues, and that just unraveled it for me, PA concept, to where I am today.
Dan, I wonder, is it useful for you to talk about how it started in the university? Because you've been there from the start. I've only recently kind of come on board because the school's just come on board.
The program started with its first intake in January 2017. How the program got started was kind of a vision within the School of Biomedical Science and Faculty in Life and Health Science about seeing a need here and pushing it through. And in the early months and year of the program, it was clinicians like Gareth and others who championed the role and took the students under their wing as a new role into the health service here and guided them through the system. So I've been involved from the first kind of a year into the program to date, and we're now in our seventh intake of PAs coming into the program.
I wonder as well, just to give that little bit more background, I think that inevitably whenever there's a new educational initiative, anything clinical in particular, it needs considerable support from a lot of stakeholders, is that engagement with the Department of Health in Northern Ireland, and then also with trusts, as Gareth says, because clearly without Department of Health commitment to funding the development of the profession of physician associates, it really was unlikely to go anywhere. So we've been very grateful for that support coming from that level. And of course, it's not just about working with trusts, but it's also enabling GPs to take PA students on placement. So we work very closely as an institution with all of those groups to kind of make it happen. It's there's always a lot goes on behind the scenes, James, as I'm sure you're probably aware.
Oh yes, definitely. I can appreciate how these things have to come together. Can you give me a picture of the health service in Northern Ireland? Are you facing the same workforce problems and A&E waiting times and ambulance problems? And are you run in the same way as the NHS is run in England?
I think Gareth is well placed to answer that from a hospital perspective.
Yeah, I suppose from a hospitalist perspective, we are supposed to have an integrated health and social care system in Northern Ireland. How that functions is somewhat variable. Certainly over the past number of months, we have seen our bed occupancies go up by at least another 10 or 15% beyond what they were, with lots of new pop-up wards and areas and things like that. So there is an extreme amount of pressure on the system. There are many, many reasons for that. There's no clear one reason. And what we do, however, have to deal with is just more complex and sick patients coming through, people who need our help and need that multidisciplinary, effective interventions, not only to treat their acute illness, but also to set them up for going home, not to come back again, tweaking their medicines, liaising with the GPs and other community colleagues. So it is really complex. And that's where some of the fun happens as well. It's not all doom and gloom. And we certainly in the Northern Trust have been very privileged to have strong links with our community partners. And I think that our PAs have really played into that in terms of a new profession coming in and being accepted by nurses, doctors, physios, pharmacists, and everything else as another piece of that jigsaw puzzle. All the trusts are trying to find money to actually employ the excellent PAs that the local university is producing every year.
And perhaps if I pick up on the situation in general practice, we have begun in Northern Ireland to roll out pilot areas where we have multidisciplinary teams working in general practice. And my practice is one example where we have, alongside the GPs and practice nurses, we have practice pharmacists, practice mental health workers and practice social workers. And that has made a huge difference to the way in which we manage the workload. I think that it is a matter of time until we're able to add PAs to that multidisciplinary team. And I can see that they have the potential to add real value to the team. I think it's fair to say, Gareth's making, kind of being positive about it, but we have the worst waiting lists in the United Kingdom. And I found it deeply shocking when I came here as a GP to realise just how bad things are. And of course, as a GP, the challenge for us of managing that burden for our patients is that there are some patients for whom it's hard to even justify making a referral because it'll be 5 years until they have an outpatient appointment. Yes, that's exactly what it's like. So neurology, elective orthopedics, it is a truly mind-boggling situation. Now, the downside of that is that patients might, if they can afford it, choose to go and have procedures done in Europe. Now, if we're lucky, that would be across the border in Ireland. But of course, a lot of patients might choose to go to places like Turkey to have procedures done. So that's challenging in itself. And the other challenge is that for people who are sick, if I were to just take orthopedics as an example, they're unable to potentially work or perform their normal day-to-day activities. That two things happen. One is they become economically inactive. So obviously the costs of that ramp up, and we're trying to maintain their status, their condition with analgesia. And so actually, when you look at our prescribing rates, they're also very high. So the knock-on effect of all of this is that, certainly from my perspective, where I sit as a GP, it's a challenging environment. Now, it doesn't mean it's all doom and gloom. There are plenty of opportunities to enhance what we do, to introduce quality improvement initiatives and to diversify our workforce. But I would say it takes goodwill to make that happen, and it takes a commitment to employing people and making sure the funding goes the right way in order for that to happen.
Wow, I had no idea that it was quite so different. I know there are obviously pockets of disparity throughout the UK, but I didn't realise it was quite so dire. It's not run by the NHS. It doesn't exist in Northern Ireland, is it? It's the Health and Social Care, HSC. But the model is the same, right? Free at the point of use.
That's exactly correct. Yes. So in England, it's NHS England, and here it's the HSC.
Dan, if I come to you, you're a physician associate. You have been a practicing physician associate. What was it like in those early days for you as a PA?
Going back to when I was a student, I was at the University of Aberdeen, kind of 2011 to 13. And at that time, there was only there was one other programme in the UK running. And the reason I chose it was a kind of a light bulb moment of the role, and I thought it was a perfect fit for me. And a lot of the time you're going out there with an idea in your mind what the role is, but you never seen anyone who was actually doing the role. And when you're going into areas that are a bit unsure of what your role is, it can create challenges. But part of that is introducing yourself, having that clear explanation of what the PA role is and what you can do, what you can contribute, and what you can't do as well. Big part of it is patient education, explaining to the patient, I am a physician associate, I'm not a doctor, and my role here is X, Y, and Z. Then as with time, with working with various colleagues in the team, you build up that trust relationship, I think is a really key part of the PA role, where the team knows what I'm good at, where my limitations are, and equally I'll recognize that and know when to seek help. And I think that's the key part of it, is just that trust relationship within the team and getting to know each other's strengths and weaknesses, and over time just building that skill set and upskilling in various areas. But in the early days, we had lots of enthusiastic clinicians supportive of the role, and had seen a demand to improve service and drove through. And again, you have those early adapters in smaller numbers, and then it becoming more and more. Where we're at in Northern Ireland, we were the last of the four nations to, one, introduce a programme, and two, to employ PAs. So we're probably a lot further behind compared to various areas of England. So we're probably in that, there's an accepted proof that it works, but it's still in its early stages where it's finding its feet and looking to expand scope of practice compared to some of our colleagues in England. So, for example, our first cohort from Ulster graduated in the summer or spring of 2019. So they're upskilling in lots of areas. Some may be considering a bit changing the specialty that they're working in. Others are looking to take on maybe teaching roles, research roles, or other things like that. So that's kind of where we're at currently, and kind of the journey that I've been on over the last few years.
Perfect. Thank you, Dan. And does the Faculty of Physician Associates work across into Northern Ireland, or is there something equivalent or different for NIPAs?
The Faculty of Physician Associates does have regional representation. So that was a recent introduction. The previous FPA president, Jeannie Watkins, originally from Northern Ireland, so I guess would have been had input into the development of a lot of this in the early stages, as championing it and speaking to lots of different people in the early days. But we do have FPA representation, and the FPA do, come along and meet our students and graduates as part of their, regional engagement activities as well.
And in England, currently, physician associates are an unregulated profession. And in England, we know that they're going to become regulated by the General Medical Council, which will lead on, hopefully, to the ability to order X-rays and ionizing radiation scans. And down the line, we hope for prescribing rights. Is that similar to the setup in Northern Ireland? Are you awaiting regulation? Is that through the GMC, or is that a different body?
All exactly the same. So the Department of Health and Social Care will oversee the four nations. So we'll be exactly the same as England and Scotland and Wales.
And given that physician associate programs now within the School of Medicine, the GMC are visiting the School of Medicine regularly because we're going through a process of approval of the new MBBS program. So the GMC have generously rolled two visits into one. So we're all in it together. But I think that's been a very positive thing, to be honest with you, James. I think that having the benefit of a great deal of experience of GMC kind of requirements and visits within the MBBS team enables us to support colleagues in the PA team with how to approach that. And actually, I think it's been helpful for the GMC team to know that we work very closely alongside each other.
Yeah, I agree, Louise. And I think, I've done some work with the GMC, and they're particularly keen to hear the experiences of the devolved nations so that they have a four-country approach. And I think it allows us to then input into sensible discussions about the practicalities of when PAs are regulated and do have prescribing rights. I think we have a wonderful opportunity, certainly in Northern Ireland as well, to craft a programme with the university, with the trusts, that allows PAs to not only continue to be properly trained in prescribing and pharmacology, but to really hit the ground running with a carefully managed environment where they do become effective prescribers of whatever set of medicines that they may be prescribing as well. And it's a privilege to, I think, feed into that process with the GMC and with other partners as well. And certainly I regularly get links and, stakeholder emails from GMC asking for your views on documents and that. So I think even though we are a small nation relative to England, we do have an important voice, as do all the other devolved nations as well, in shaping policy around this vital area.
And to my mind, if we're all trained the same, we're all GMC regulated, there's no reason why PAs that are trained in other parts of the UK can't move to work into Northern Ireland, or Northern Irish PAs coming over to work in other parts of the UK. It makes sense, doesn't it, for that part of the workforce to grow?
James, I'm biased. Northern Ireland is a beautiful place. Come visit the North Coast, the city of Derry, the Moor Mountains. The work-life balance is brilliant. And yeah, we will have PAs that are English trained. I was Scottish trained and come home. So I guess my goal, and I suppose the department's goal and the school's goal, will be to train and retain our graduates, whether it be in medicine, in nursing, or in physician associate studies, or any other healthcare profession, to want to stay here if you want to.
That's such a wonderful advertisement for this area. And, you can guess from my voice and my accent that I am not from here originally. I moved here for work, and I'm absolutely delighted that I did, because the quality of life is indeed second to none.
Brilliant. Thank you, guys. Is it fair to say that numbers of PAs in Northern Ireland are still quite small? How many PAs are there? How big is the profession?
In terms of numbers of PAs in Northern Ireland, I think we're around the 60 to 70 mark. We have the first cohort that graduated in 2019. There was 11 students in that group. With support and funding from the Department of Health, we now have spaces for 20 PAs per year. And that would be the number that we'll be putting out for the next couple of years. So we're hoping for a steady stream of PAs going into the workforce, with a steady mix but across the 5 health and social care trusts as well as primary care. We've about 5 PAs working in primary care at the moment, and our PAs are spread across a whole range of specialties already, in hospital medicine right down to neonatology, paediatrics, obs and gynae, cardiology, acute medicine, emergency medicine, mental health, and there's others I've missed out there. But we're starting to see that breadth of roles being available to the PAs, like in England, as well as departments looking to add a second PA into the team as well. So it's growing steadily year on year, but ensuring the steady stream coming into the workforce and keeping them here.
And is Ulster University the only course in Northern Ireland to study as a physician associate at the moment? So the large majority of PAs will be studying elsewhere and coming in?
Yes, so we, as you say, James, we are the only university which is running a physician associate training programme at the moment. So either PAs working in Northern Ireland have been home trained, or there are some, as Dan alludes to, who are sort of coming back home.
Perfect, thank you. I did an episode of this podcast with some physician associates in New Zealand, and I think they could count on one hand the number of PAs that they have working in the entirety of the country. So it's small beginnings, but it is growing across the world. So, Gareth, can I bring you in? As a consultant, you've worked with some of these physician associates in your day-to-day job. How do you sort of find your experience of the role, and how do you advocate and sell the benefits of physician associates?
Yeah, I think there's actually 2 parts to that. First of all is the student experience, and then the qualified PA experience. And we take on quite a number of students throughout various disciplines in the Northern Trust. And what I found as an educator is that the PA students in their second year are already very workplace ready. So we give them access to some of our electronic systems. We have an integrated health and care record called NIECR, where they can view lab results, letters, and so on. This allows us to give them the ability, for example, to do discharge letters, to follow up on bloods, with obviously the supervision of others around them. But they're very much workplace ready, and they contribute to the work of the ward round. They contribute to the work of the junior doctors or nurse practitioners, and it helps them to integrate very well into the team. So they're already socialised. The concept has been socialised very quickly. So they get access to training areas it's easy for me to sort of ask a friend in gastroenterology or rheumatology and say, look, could a PA come to your ward or your clinic? There's no problem because they know what they're getting. This is carried through then on to the qualified physician associates who very rapidly are able to start to develop specialist areas of interest. We have one PA who has been working here for just over 2 years. She's now got all of her exams in echocardiography and is doing echoes independently and teaching others. Another PA is teaching lumbar punctures to junior doctors and registrars, supervising them, helping them to get their sign-offs. So instead of taking away procedural opportunities, they're actually augmenting the training opportunities for others, as well as providing that consistent, high-quality service themselves. Other PAs are taking training on in leadership. There's a leadership course that's run over in Liverpool they're involved with. Others are doing rostering, and many, them all as a group, are helping with the many changeovers we have to provide that almost sort of continuous, if you like, workplace induction, which we find incredibly helpful as well. So my experience of them has been overwhelmingly positive, consistently across the number of years, and that has been true of the rest of my colleagues, certainly in the Northern Trust.
One of the barriers when I'm sort of advocating for the profession, doing my ambassador work, explaining what a PA is, one of the barriers that often gets thrown up against our profession is a lack of regulation and a lack of prescribing rights. In practice, do you find that to be an issue?
No, but we don't. There's been a lot of theoretical concerns about this, but when we actually work in practice, certainly in acute medicine, we tend to work in parallel. So we see a patient, things are prescribed, medications are altered, scans are requested, fluids are decided upon and prescribed. And that is done whether it's myself and a PA in the ward round, because I know that the time that I spent ordering a scan, prescribing fluids is more than offset by the physician associate making an excellent referral, doing a well constructed discharge letter and assessing the patient correctly. So that has not been a problem. We are trying to get PAs to have some limited ordering of radiology scans, such as ultrasound scans, which don't require radiation, don't require procedure. So there's certainly ways around that, but it has not at all been a problem for us. And I have done many on-call shifts, weekends, with lots of outlying patients in the emergency department with just a physician associate and myself. And it's always been a pleasant experience. I've not felt, oh, why am I doing all these routine tasks? They're not routine tasks, they're tasks the patient needs, but the PA is doing lots of other things as well. So it's not that there's extra work being generated, it's just the work is being done better and well.
You know, it's actually tribute to the quality of their education, both in the university and in clinical settings. So if you look at their success rate in the national exam, our graduates have performed really well. And I think that just speaks to all of the things that Gareth has been saying about sort of their quality and ability to deliver in the workplace. Thank
you. And you mentioned in your answer about nurse practitioners and other members of the workforce. How is that? How are physician associates integrated? Are they well received and supported?
Yeah, I think initially, I think the first week or two we had a PA. There were all sorts of comments about discharge letters, and one of the F2s felt that they were going to take away teaching opportunities. And actually, by the end of the week, it was all sorted. So I think there had been naturally a little bit of suspicion there, and I suppose one of the things is PAs are starting at band 6 or band 7 level, which potentially could lead to other professions questioning why they've worked so hard and they're, still at band 5 level or whatever. But actually, whenever people have seen what the PAs do and the type of people they are, it just breaks down those barriers. And now the people that were initially a bit suspicious are some of the best advocates for PAs in our hospital and work with them very well and value their expertise.
The term they use that may not be familiar across England, we help to embed the PA role into the workforce. We have the trusts have developed what's called a new graduate year. So their first year is at band 6, and they would usually rotate around a couple of different specialties to get experience of some different areas. And then at the end of their band 6 year, once the supervisor signs them off, they'll automatically progress to band 7. So part of that, the rationale was that there was allow the teams to understand the PA and the PA to embed into the team. And that has just stayed on since then. We had a regional PA implementation group that was represented by all trusts, chaired by a chief executive of the Northern Trust, with representation from the Department of Health and the university. And that helped to develop policy documents, governance, and the structure around the delivery of the programme and the education and training that has led to the good results that we sit on today.
Brilliant. I guess the other questions for me would be how education might differ between Northern Ireland and the rest of the UK. Could you tell me a little bit about how your course is structured at Ulster and things about student finance and applying to PA school?
Yeah, certainly, James. The Physician Associate course at Ulster sits within the School of Medicine and then within the Faculty of Life and Health Sciences. So our base is on the Magee campus. We have, as I said earlier, 20 students that come into the course each year. How they are funded, the Department of Health provides generous sponsorship of tuition fees. So those who get a place on the course get their tuition fees paid for year 1 and year 2 of the course. In terms of postgraduate and career development loans, there's not very many avenues available in Northern Ireland for that. So students often have to self-fund cost of living, either through personal loans or family or personal savings. So the tuition fee support is really important to the students. In terms of how the course is structured, we would have that traditional, mostly didactic year, followed by year 2 being placement year. We teach a systems-based approach. We have various integrated methods for delivering the programme. The programme is mostly delivered by experienced PAs, as well as local experienced consultants and GPs. Many are very passionate about their specialty and their area of expertise, and that translates really well to our students. We try as much as possible to have students in placement as early as possible in year 1. So we try and bring our students out to placements in the middle of year 1. Now that we've several cohorts out there, which has run in recent years and been really successful, is we will have our year 1 students buddy a qualified PA. So they actually get to see a PA in the flesh and what they do day in, day out. And I'm thinking back to when I was a PA student that I had an idea in my mind what it was supposed to do, but didn't get to see that. And our students love that. And the students that are on our former graduates really enjoy that, because again, they get to pay it forward again of what happened when they were students. And kind of what I kind of want to add in is the quality and of the educators in the university, as well as the clinicians in practice, the GPs and the consultants and the senior doctors, provide excellent level of support. And where it makes it easy for me as a course director to support and actually see the end point. Like, we've excellent outcomes in our national exams. So as Gareth was alluding to earlier, workforce ready in year 2, being hands-on on placement, be able to help out with workload. And that makes it hopefully easier for an individual practice or an organisation to advocate for employing a PA in their department. So we now have lots of people advocating about employing a PA in their area or adding another PA in. So it sort of has that cycle. And I guess what I'd like to see in future with bringing in our experienced PAs that we've trained to help train the next generation as well, so that the cycle kind of goes on and on.
And in terms of, if anybody's heard this podcast episode and thinks that they might like to train to be a PA, how do they go about applying? What sort of prerequisites do they need to get in?
At Ulster, you'll need a 2-2 degree in a life science or health-related subject, usually completed in the last 5 years. There are non-standard entries, but that's answered on a case-by-case basis. If you go onto the Ulster University website and type in Physician Associate Studies, you'll see the course and the detail of the course information. It is a master's programme. Part of the work towards the master's is developing a research project in year 2 and making sure that you're ready to be involved in and participate in research when you qualify as well, so that you have an impact in quality improvement and patient care as well. So it's 2-2 or higher, and the rest is all outlined on the website, and there's contact information on the website if there's any questions that you'd like to ask us that isn't outlined on the website.
I think that based on the years of experience that we have to date, and listening to what Gareth has had to say about the role of PAs within the healthcare workforce in Northern Ireland, I think that there is going to be nothing but expansion, actually. You'll have heard from what I said earlier about the nature of the demands on our workforce and from our patients, and just the extent of waiting lists and so on, that we need a diverse, skilled, caring, capable workforce. And I see that physician associates are and will continue to be an absolutely integral part of that workforce for the future.
Perfect. Thank you, guys. Thank you all so much for joining me on the Physician Associate podcast. I appreciate you giving up the time.
Thank you, James.
It's been a pleasure. Thank you very much for inviting us.
And thanks to you for listening as well. I hope you found that an interesting discussion to find out a little bit more about physician associates in Northern Ireland. It certainly opened my eyes up to how some of the differences between the UK. If you're a physician associate, or if you've got an idea for a future episode of the Physician Associate podcast, I'd love to hear from you. Please get in touch. I'm on social media at PA Podcast UK, and I hope you'll join me again for the next episode.
Thanks for listening to the Physician Associate podcast.